Thank you all. I think we can get started. This webinar is a continuation of what we had started on June 25th. We had, on the first day, we had a discussion on, especially on the use of contact investigation for tuberculosis, and we touched upon COVID contact investigation. But today, our focus will be mostly on COVID contact investigation, and then we'll wrap up with some discussion on the combination of the two approaches. So the webinar will begin shortly, and you will be muted. All the attendees will be muted by default, but there is a function, whenever you have a question, you can type it to the Q&A, and there is also an option to chat with the panelists on any topic you want to discuss. So I'll now move to introducing my first speaker. Dr. Peter is a public health specialist with many years of experience in the public health sector in Germany as an internist and a respiratory physician. He has many years of experience, and he's currently the director of the Institute of Hospital Hygiene in Minden, and the clinic of the University of Bochum, Germany. So he has been coordinating the COVID response in Germany. So he had a very important role there. And also we know that Germany has been very successful in many ways, as per news that we hear. So he will share his recent successful experience in leading contact investigation, among other things, for the COVID-19 in Germany. So Peter, the floor is now for you. Thank you.
Thank you, Degu, for this nice introduction. Ladies and gentlemen, I'm glad to present our experience from Germany. So we have in Germany first contact with COVID in January, February, and I first want to show how I work. This is the hospital with 930 beds and around about 5,100 employees at 5 hospitals in the county with 1,900 beds. And we make the COVID patients in this house for the whole county. Here you can see the graph of COVID 2020 worldwide, and you can see it started in February, and in February we had in Germany the first cases, and actually we have 194,000 cases, which means 234 cases per 100,000 inhabitants, and just today we have now 9,000 deaths. The first case in Germany was in Baden-Württemberg in the mid of February. This was a contact to Wuhan in China, and we made then for the hospital instructions for the employees in the hospital dealing with COVID patients. We had no patients in the region at that moment, but we want to be prepared and want our nurses and doctors be prepared. And this graph shows you how it goes on. We started early in March and then had a peak in the middle of March, and then it decreases all the time until today. The main age group was the middle age group in Germany, 35 to 59 of age. And in the county, we had the first case on 6th of March, and exactly 1 week later, we had the first case in hospital. This was due to a Bayerisch Abend. You know this Oktoberfest in Munich. You can compare both. It's 700 person in a small tent, and 15 nurses were included in an outbreak on our ICU. And here you can see what this made in the county. Here you see the graph, and here where Bayerischer Abend is started this outbreak, and the cases in the county increased rapidly. You see another outbreak was in a RIA clinic, and then you had again a peak and an outbreak in a nursing home with 2 little peaks. The county here in northwestern of Germany has 300,000 inhabitants. We have around about 500 COVID cases, and the last 7 days we had only 1 case actually, and 12 persons died by COVID or in contact with COVID. On in the end of February, we started with our PCR laboratory. We ordered distance rules for all employees and reduced the meetings in the hospital. Remember, at that time, we had no cases in the county and no cases at the hospital. In the beginning of March, we started with this mobile. We called it the Corona mobile because it looks like a mobile home. We, at that time and later on, tested all COVID suspected cases outside the hospital. No one is able to enter the hospital with symptoms when he has not been in this mobile and maybe tested. Every patient, clinical or outpatient in the county with symptoms was tested, and every symptomatic employee is tested and then released from work till the result comes in. We changed later on to container system. This is the actual picture. On the right-hand side, you see the container for visitors. Here are the containers on the left-hand side for employees, on the right-hand side for county patients. This one has a nickname, Corona Village. This is another view of this container. So, what have we done additional? In the hospital, we made a spatial separation and different wards. One ward, 15 patients for COVID, 15 beds for COVID suspected cases, and 12 beds for an ICU, which is in peak with 7 patients. Actually, there's only 1 patient. In the beginning of April, we ordered face masks for all employees. We use surgical face masks for special risks, endoscopy, intubation. We use so-called FFP2 or international called N95. Since beginning of April, we had no further COVID cases at the employees due to this surgical face mask for all during the whole time in the hospital. PCR testing now for all new patients. We put it together with the MRSA specimen taker. So this is one of our workers from the kids. Okay, and another important point is the communication. It is necessary that all nurses, doctors, employees knew what's going on. And so we, in the clinic intranet, we have a daily COVID newsletter with the newest dates from COVID in the county, in the hospital, and the newest management rules. Also, we have had a crisis unit from Monday till Sunday every morning in the county government with the public health authorities for maintaining close contact with the stakeholders concerned, which means representatives of the hospital. In this case, it was me and one of the general practitioners to speak about what to do with the new COVID cases and the situation. So this is what, in my opinion, are key for you. You have to work step by step due to your opportunities and the local situation. You have to be clear in your communication, and it is absolutely necessary to communicate what to do in the hospital and in the county. And in contact precaution is the use of face mask, surgical, for example, important. And now I want to talk about PCR tests, because we think PCR tests are very important to limit the outbreak. We started, as you remember, at the end of March. Here you see the newest testing numbers in Germany for every week. This is in the middle of February. This is last week. We have nearly 400,000 tests a week in Germany. 1.3% are positive. Here in Minden, we have actually 1.9% of all tests made in Germany. But what you have to know, you have to get the information very quickly to the patient and to the public health authority. So we have an app. Here, this is Professor Schmitz, the leader of the laboratory, and it takes only maximum 8 hours to get the result on your app, on your mobile phone, but only the negative result. The positive result will go to the health authority, and the health authority will get in contact with you. So what's the reason for testing for COVID-19? You know, it's necessary to identify infected individuals, to reduce spread by isolation, contact tracing for exposed individuals, but also provides knowledge for regional and international and national rates for the public health and intervention opportunities. But what is to say to the testing? As you know, this is a publication from Corman. The sensitivity depends on where you take the specimen. Public Health Authority for Germany, the RKI, Robert Koch Institute, says the last 2 swabs should be done in the first 4 days of the disease, otherwise they are negative. And I think this is one reason why this are so low. I think in our cases, the results are better. But what about sensitivity?
Dr. Peter, you are breaking, is it?
Can't you see me?
No, we can see you. No, no. Your voice is not coming through, Peter.
Okay.
But we can see the slide.
Yes, can you hear me now?
Yes.
Good. I had some problem with the Wi-Fi at the moment. Sorry for this. The sensitivity, which means the true positive rate. On the other hand, the specificity, which means that a patient or a person without disease, without infection, is true negative tested. And if you have a look at the tests, you see there's no gold standard. You have no gold standard to know which patient is really infected. One step is the test, another one are the symptoms, and it's like tuberculosis. There you have comparable problems. The specificity is not a problem because you can really say a person isn't infected, and so you have a good standard. And the tests which are actually used compare with another test. They don't compare with patients in large numbers. They compare one with the other, and so you often hear sensitivity is 98%. And Arevalo Rodriguez, in his publication from April, said sensitivity is really only 71 to 98. Specificity is 95%. What does it mean for the clinicians? They have to look at the prevalence in contact investigation because they want to know, in one case, the positive predictive value, which means if a person that is PCR positive tested, is it really infected? And on the other hand, the negative predictive value, which means if the negative tested person, correct negative, is not infected. And it is this one is a good result in all tests. All tests that are used are very good in negative predictive value, but they have some problems with positive predictive value in case of low prevalence. And this is comparable with TB. You know it from TST test, IGRA, QFT, which have the same problem. You have to think about the person you should test. Is it a contact person? Is a person symptomatic? Or is there no reason for testing? So Schlenger im German Ärzteblatt last week made this publication, and he said if the prevalence is 3%, which is nearly higher than in Germany, the PPV is only 30%, which means 70% are false positive. But you have to see sensitivity is only 70% in this publication. It's a little bit low, I think. 20%, which means contact in nursing home. So you have a much better PPV with 78%, and NPV is very good. Here is it absolutely good. But the problem is in 80% prevalent, which is in family context, there's a PPV very good, but the NPV isn't it. Let's have a look here. 98% PPV means if you have in a family with a COVID patient, another person with positive test, the test is right. So this person is COVID patient and is infected. But if you have a negative test in a family with family intensive context, think about 56% false negative. And when you think this person should be infected, repeat the test. So we made a publication about protection for healthcare workers in tuberculosis. And there we wrote about sensitivity from 84 to and specificity of 99% for IGRA QFT. And there was comparable results. Prevalence 5% means PPV 81%, which means 1 in 5 is false positive. But if you have a good prevalence, you have a very good PPV and only 4.5% false positive. If you want to make a decision about your test, in the British Medical Journal, Watson et al. Made a publication with this interactive graph. Here you can put in your test probability, which includes the likelihood a person has COVID based on their symptoms, the contact, etc. And the sensitivity and the specificity. And as you hear in this example C, in this case, with a prevalence around about 3%, you have in 37% probability of having COVID-19 if test is positive, which means this 3, but this 5 are positive tested, but not really infected. The negative predictive value is excellent, 92 and 92 are negative. So you can use this test very good to exclude COVID, but not to make the diagnosis. In this case, it is necessary to look at the pretest probability first. And one thing is to look at the local rates, the prevalence. You look at the patient symptoms, signs of infection, and the likelihood of alternative diagnosis and the exposure to COVID-19. This is what the Robert Koch Institute thinks about contact investigation and management in Germany. And they make a difference between high contact, which means 15 minutes or more face-to-face contact or direct contact, especially in families, or for example, all other, for example, classroom. And the management depends on this contact. In high contact, 14 days of quarantine, low contact, no quarantine. Test day 1 and day 7, no test in low. Symptoms, self-control twice a day, once a day. And this is important. When symptomatic, immediately should be tested. In both cases, when you have a person who is symptomatic and is in contact, please let them test. At the end of my presentation, I want to have a short look to antibody tests. We made antibody tests in April and May by 449 employees, nurses, doctors of ICU on infectious disease wards. And we made 395 IgA, IgG, and only 54 IgG. And the results were in many cases negative. Some IgG were 35 positive and 79 IgA positive. Let's have a look. And the controlling of PCR were, can you hear me? Hello?
Yes, we can hear you.
Okay, had some problem again. 79 cases and only 1 case was PCR positive. IgG, 88% negative and 8.9% positive. And from these 8.9, 45 persons, 27 were PCR positive before we tested IgG. So they knew their infection before, there was no new message. 40% We had no test results. In other cases, the PCR was not known yet. And in summary, antibody are not the one I would recommend to you. 395 IgA and 109 suspected cases, which leave the hospital, stayed at home, waited for their results, and only one unknown PCR positive case, and 449 IgG, 45 positive cases, 60% known before PCR positive, 40% unknown PCR. So the result was nearly poor in this context, and I would prefer testing symptomatic and contact patients, and IgG is maybe later a good to do. So thank you for your attention, and I hope it was a little bit new for you, and greetings from Germany.
Thank you very much, Peter, for this really nice and very insightful presentation. These are aspects that we didn't cover in our first webinar. So I'm sure some of the audience, the participants may want to say a few things. I will allow them to speak, especially if there are colleagues from the KNCV here. And they can also type their questions to the Q&A. I have one question, Peter, for you. Because this discussion on the sensitivity and specificity of the tests is very, very interesting, because we receive the positivity rate, from many countries, but we don't know, which specimen was being tested, and so. And as I see from your presentation, I think the bronchoalveolar lavage has the highest yield. Is that correct?
Yes. We think that SARS-CoV-2 decreases to the lung, and if it's a pneumonia, you can't get a positive specimen in the nose or in the throat. So this is the reason why the results are much more better in bronchoscopy or bronchoalveolar lavage.
Okay. I also see that you started, you detected your first case in March 2nd, I think, right?
Yeah, that's right.
So were you really prepared for this kind of pandemic at that time, or it took you some time to set up the system, even in Germany?
We first compared it with H1N1, which we call Schweinegrippe, in 2009. And the way and the management to work with it, we used now for COVID, but we had to learn that COVID is much more aggressive, and it spread much more easier than influenza or H1N1.
Okay, thank you. So another question. Sorry for too many questions, but I'm sure others will also want to say something. What was the experience of your clinic in terms of managing TB contact investigation? Is there TB in your clinic, or do you do TB contact investigation also?
We have just around 20 cases of TB only in the county. The incidence of TB in Germany is very low, with 6 cases to 100,000 inhabitants. And we have in the clinic just around 90% of all these tuberculosis cases. It's getting more and more difficult, the contact investigations, because the person with tuberculosis are very mobile, and 80% of them are not born in Germany, so it's sometimes difficult to meet them and to make the contact investigations.
Thank you. So I have one question from one of the participants, and from Amikul. The question is, we have cases of PCR negative, but clinically positive cases of COVID. Do you have such cases?
Yes, we have two. We have two kinds of cases. We have the one we think they are COVID patients infected and PCR negative, especially with a view on the X-ray. And in this cases, we make a bronchial lavage. If this one is negative, you should have taken specimen from the lung. And then you will find a positive PCR. Many cases that we think they are not yet infected have PCR positive tests. The longest one has 100 days positive test.
Okay, thank you. There is a follow-on question also to this one. You mentioned about the importance of testing during the first 4 days of the disease.
Yeah.
So why do you think is it so important?
Because it's the only way to take a good swab from the nose, and after 4 days there's a decrease of SARS-CoV-2 to the lung and to the bronchial system, so you can't get it, and the test results are more bad. So,
okay.
So earlier you test, so better the results, and so earlier you are able to make your contact investigations and detect other cases.
Thank you. Another question from my colleague Nisha is, she's saying, I understood that close contacts are tested twice for COVID, and she also saw that then the negative predictive value is quite high in high prevalence settings. So what is the consequence of for those close contacts?
I would say the close contacts with negative test should be tested again shortly.
Okay.
I would recommend a second test 1 week later due to the difference between infection and disease, the incubation time.
Thank you. Another questions from my colleague, Dr. Kone, is in situations with a low expected prevalence and in the absence of COVID-like symptoms, you recommend to do the test again. So can you use the same test, or do you use another test in that case?
The same test. The same test. We recommend this test only at persons which are asymptomatic when they have contact. If you have a person low prevalence, no contact, no symptoms, the test will be wrong or negative.
Thank you very much. Another question from my colleague from Botswana, Dr. Tafarra, is asking, is saying, Germany is one of the countries that started massive testing as early as February. What helped you to get the test ready in massive scale? How did you get that amount of tests so quickly?
One reason I think was we started getting the hardware in February. When we saw what happens in China, Wuhan, you saw Professor Schmitz on one of this picture with the app He was at that time in Switzerland and had connections to the USA and ordered this hardware for the laboratory. And this was the key to get these hardware for the tests.
Thank you very much, Dr. Peter. Another question from our technical director, Dr. Agnes. Agnes, if you want also to say a few things, I can allow you to speak. She's saying, thank you for the presentation and sharing some of your experience from Germany. Do you have any indication for the duration of immunity for COVID-19?
I didn't understand the question.
The duration of immunity, after infection.
Yeah, good question. We hope that with antibody test, this will be clear, but it doesn't work. You have to make a neutralization test on this, but we don't have this in great number. We think 4 weeks after the disease and 4 weeks after PCR first test positive, and with IgG increasing. In these cases, we
You're breaking again, Peter. Maybe the internet.
The first PCR positive tests and normal immunity and IgG increasing 4 weeks later, then we think there is immunity, and we don't further look on the PCR results.
Okay, there are some questions now more specific about contact investigation coming. So in your contact investigation procedure in Germany or in your county, who is responsible for the contact investigation when a patient with COVID is detected? Can you explain the procedure a bit?
Yeah, for the inhabitants of the county, it's a public health authority, which will be informed of a positive test in hours. On Sunday, it's equal Sunday and Monday, every day of the week, they work, and they start the contact investigation immediately. If we have a PCR positive case in the hospital, we, as the Institute of Hygiene, start. And at the same time, we give the information to the public health authority, and they start the background in the family and at the working place, so on.
So is there a kind of house-to-house visit, or is this done just by phone or using apps?
First visit is house-to-house. And further on, they are in contact every day with the cases and with the contact persons, especially with the contact persons, to ask them about symptoms. Because if they get symptoms, they have to be tested immediately.
Okay, so is this house visit, for example, done by nurses or specially trained tracers, or who's doing that?
Nurses of the Public Health Authority.
Okay, thank you. Rachel, if I missed any other question, please flag that. And I also see, I know Peter has been answering too many questions, but if others want to say a few things, maybe if you show me some sign, I can allow you to speak before I present the summary. I see Jeremy is also here if he wants to say something. Because it's, would you like to say something, Jeremy? Sorry,
Hi.
Yeah.
Yeah, Jeremy here from KNCV. Thanks very much for the interesting presentation. It's very helpful. I I think, and I joined at about I think some minutes past, so I think I caught most of the presentation, perhaps all of it. I think from our side, we're very interested in the way that knowledge can be transferred between the disease areas, particularly when it comes to implementing the testing and treatment programs and contact investigation. And I appreciate very much you presented the link in terms of the performance of tests depending on the population and the way that informed your own approach. So I just wonder if you could comment. What I would like to hear about in some more detail is whether there is amongst the implementing staff, your contact investigation workers and others, how did you manage to how much did you manage to transfer the knowledge between from TB control activities to the COVID program, and what recommendations would you make about being able to kind of adapt in other settings existing TB programs and include COVID related activities?
If you compare TB with COVID, it's quite similar due to the tests. I see in Germany that the QFT and the TST are over-interpreted. They think the test is very good and says everything, and one who has a negative test is really negative, and one who has a positive QFT has to have a TB, which is not real. And what we now again learn is to look at the patient, and the first thing of all is look at the patient, look at the contacts, look at the symptoms. This is the main message from me, not look all the time at the tests.
Thank you very much. Agnes, are you able to speak if you are not in a meeting or somewhere, doing something else? Do you want to comment, on overall in this contact investigation in the COVID and TB? You have something to comment? I think Agnes is either muted or she's not available. I'm just randomly asking, so I have to apologize that our presenter from Ethiopia was not able to join us, and most of the people, because of some major problem with the internet there. But we have another presentation which I prepared. I can summarize a few things, but I think this discussion is interesting with Peter because he's not, we can't find him very easily. So I will allow, also ask Connie to say a few things. Thank you.
Yes, thank you, Diego, and thank you very much, Dr. Peter Witte. I just wanted to react to your point on testing in a low prevalence situation, and that it is really in low burden countries like Germany and the Netherlands that for TB that is indeed also a big concern. In my presentation last week, I also tried to point out that as a first step, a risk assessment of who are the contacts and who are really eligible for evaluation and testing is therefore essential. And I'm very happy that you have presented the scientific evidence for such an approach, and I do think that in countries where COVID epidemic is wearing off and is becoming low prevalent, like it's becoming now in Germany and the Netherlands and other countries, this is really a very important message to convey, because we have to be sure that the cases reported are indeed the real cases and not false positive cases due to all the other social and economic consequences there are. And I'm very happy that you have stressed this point. Thank you very much for that.
Thank you, Connie, for this. Peter, do you want to say a few things to that remark?
Oh, I think Connie is right, and this is one of the main recommendations, to say that the negative test result is at low prevalence very good, and it's correct, but the positive tests take care.
Yes, thanks very much for that.
Thank you. Do we have anyone from Nigeria? We had some nice experiences being discussed yesterday, but I'm not sure if the Nigerian team is available. Okay, I don't see. I think anyone else who wants to comment from Africa? I see Dr. Tafera is there. I'm sorry for I'm picking people randomly, because maybe if you have any comment from Botswana.
No, thanks, Dago and Peter. No, we appreciate the presentation and giving us a perspective of the predictive values in high and low prevalence settings. The only question I had was what I have asked already, and thanks for the answer. Otherwise, in Africa, as you know, things are picking up here. We are really struggling, how to cope with the winter now in this side of the world. But more our cases are more of, at least in Botswana, cases are coming from South Africa. Truck drivers are the one giving us more than 85% of the cases. So we are handling cases at that level. So with that, we may not expect that much of a problem in Botswana. Mm-hmm. That's all to share with you. Thanks.
Thank you, Dr. Tafera.
Diego, in July will be a DZK recommendation from our National Tuberculosis Institute, and we like KNCV in the Netherlands, which is about tuberculosis and COVID in common in one patient. It will be published in 1 or 2 weeks.
Okay, thank you. Thank you for the information. All right. I don't see any more questions, or maybe I missed some. No question is open now. Okay, so if you don't have any other comment or question from my colleagues here, I may rush through a few of my slides, from the last week presentation in 5 minutes, and then we can wrap up, right? Okay. I believe you can see my slides, right?
Yes.
Yes.
Okay, thank you very much. This is going to be a very brief presentation. It can actually take up to 30 minutes, but I deliberately wanted to make it short because we had a nice discussion already with Peter. So I don't want to spoil that going back into details of TB contact investigation. But last week we had a very good discussion with Dr. Ahmed from Ethiopia and Dr. Connie from here, from the Netherlands. And we started with defining what contact investigation is. That was a basic thing. But also we looked at the similarities and differences between TB and COVID. So these two diseases we can't simply say that they are the same, very similar, there are differences. The mode of transmission, there are some similarities with the way how it transmits, but we also know that there are important differences. For example, TB is mostly aerosol infection, and COVID is mainly through a droplet infection. The presentations, there are some asymptomatic stage in both diseases, but TB is typically slow, but it can also sometimes it can be very fast, but not as fast as COVID, because that occurs within 24 hours. And the incubation period is obviously different because for COVID it is less than 14 days. The average is 5 days. For TB, it can take up to life, so that's a difference. But in terms of diagnosis, we heard even more clearly today that the PCR test is good, but there are also differences in terms of yield, which depending on prevalence, and also the sample that you use for testing, which is very important. The same with TB also, by the way. We also have differences in terms of yield, depending on which sample we use. But the more important is TB is diagnosed differently. We use microscopy also, which is not the case with COVID. So these are some of the differences that we know. The high-risk group is different, both different and similar. There are, contacts are definitely, at risk. Direct exposure for both cases puts them at risk. So they are similar, but we now know that COVID differentially affects people with comorbidities such as cardiovascular disease, pulmonary disease, and people with age over 70. Whereas TB, children are at high risk in TB, which is not the case with COVID. So this is another difference that we have noted during the discussion we had. So these differences, they really make also a difference in the way how we approach the two diseases. But in terms of preventing infection, I think there are more differences than, more similarities than differences, because the personal protective measures and the environmental and administrative measures that we take to prevent TB are also very much in line what is recommended with COVID, but slightly stricter, more stricter because of the problem. But the triage systems that we have seen, the personal protective materials that we have seen, all are also in use for COVID now, which is the similarity that we have noted also in our discussion last week. The guiding principles, I was very happy when I see the way how Peter started his presentation also. The guiding principles are not very different, in terms of contact investigation, integrated care on community level. In Netherlands, they use a nationwide network of local public health services. And Ethiopia, they use health extension workers, which is the same, almost. The people-centeredness of the services is also, applicable for COVID. The need to avoid stigma, preserving confidentiality, they apply to any disease condition, and communication. Miscommunication and disinformation. This is really causing more harm than the disease itself in some parts. And I have heard people after being quarantined, committing suicide because of fear of dying of COVID while they were negative after testing. so these things are still relevant for both COVID and tuberculosis. Especially with MDR-TB, we had a similar problem when we first started to diagnose MDR-TB. The approach, sustainability and affordability of the practices. So we focus on the ones closer to the source patient, to the index patient, both in TB and COVID. And then depending on the resource and our capacity, we can expand the contact screening, which is also applicable. Making costs, services free of charge or covering through insurance schemes like it is done here in the Netherlands is is very important in order to have access to the services. So these are some of the guiding principles which we have noted during our presentation last week. So these are applicable. This is a slide from Ahmed. I made it compact. This was presented in 3 slides. So what do we do, in a low resource setting, in a high TB setting, burden setting? At health facility level, we have index case identification process starts there usually, and then contact tracing, screening for contacts, and doing more further investigation of presumptive cases, diagnosing them, treating them, and using the opportunity also to educate and to provide preventive therapy to those who are not TB positive is another. These are the activities performed at health facility and at community level. The contact tracing, once they are informed, they do contact tracing, primarily by visiting the houses. Then the contacts are usually they are, for COVID, they are referred to the COVID treatment centers. Or we also refer specimens, and health education, adherence support, and follow-on screening. These are standard services provided at community level in a setting like Ethiopia. But at the administrative level, there is a lot of work, including registration, supportive supervision, and reviewing the progress and giving feedback. So these are the standard approach used in countries like Ethiopia. So this is the steps that I just described, the steps in TB contact investigation, starting the most, those closest to the index case. This is a recommendation from African CDC, depending, contact investigation can be done, can be tailored to the epidemiologic scenario of the country. So if there is no case, which is no more a case now, because all countries now have, I think, reported, then you can invest your time more on preparation. If you have clusters of cases, then you can do exhaustive contact tracing. And then if you have imported and local transmission already established, then this can still be done. But if you have widespread sustained community transmission, then the focus should come and narrow down it to the household level, because doing contact investigation to everyone is, especially widespread community contact investigation, is of low yield procedure and not necessary. So key lessons we learned is that lessons from the TB program, contact investigation can benefit the COVID response, all the steps involved in TB contact tracing, and the subsequent monitoring system that we have established can also be tailored to the benefit of the COVID response. Since COVID is likely to stay longer in Africa because of the nature that we see, thinking of more integrated approach for the 2 diseases is essential now. We have to work on guidelines and algorithms on those. But also from the COVID response that we have seen now, we can draw more lessons to reshape our TB prevention and control strategies. So this is a summary of things that I presented. I acknowledge Dr. Kony and Dr. Ahmed for the slides they shared with me last time. Thank you very much. If you have questions, you can type them here. Otherwise, I think I should thank the audience. We'll share a summary of this discussion. And we have already shared the summary of the previous, last week's presentation, and we will share this one also with everyone. Special thanks to Dr. Peter for taking time out of your busy schedule, we know. And I would like to thank the audience and my colleagues here in KNCV for the good coordination of this webinar. Thank you very much.